The agenda for tonight is that we'll proceed to the lecture. The lecture will take about 45 to 50 minutes, followed immediately by question and answer and comment and contributions. Then there will be chairman closing remark and closing prayer. Before the meeting, we want to recognize the CPAN chairman, Dr. Joseph Mahdi, and all the CPAN ESCO, eminent personalities among us, fellows of PSN, fellows of WAPCP, all the state CPAN coordinators, all the CPAN VIPs, all our new members. You are all welcome. And especially want to welcome our guest speaker from UK, Pharmacist Ibrahim Rahman. You are welcome to our midst. So in the next few minutes, between 45 to 50 minutes, he will be telling to us on management of diabetes. I want to call on Pharmacist Rahman please to start the lecture.
Hello, good evening, everyone. I'm sure some of you might know me, so I changed the topic as Dr. Bello said just a few minutes ago because I felt there is more to our patients than just medications. And as clinical pharmacists, we should go beyond medications. We should not just be talking about medications. There are other things that we should be doing about our patient. We should be taking an holistic approach to the management of our patients. And that is what we do day in, day out here. And I feel that maybe at the end of this discussion, we might be able to take one or two things away from my experience working as a prescriber and prescribing for some of these diabetes patients. My doctor, I'm only going to be focusing on type 2 diabetes, which I think is the most common one, type of diabetes, and usually arises as a result of things that we could actually manage between ourselves. So, I wouldn't waste too much of our time because there is a lot to go through actually. This kind of presentation, if we truly want to really do it, as I told Dr. Bello, it should take us about 2 or 3 presentations, but I'll try as much as possible to squeeze so many things. I hope you bear with me as I rush through some of these things, and maybe you can then ask questions at the end of the whole presentation. So let me try and share my screen if I can do this 1 second. Can everyone see this screen?
Yes, we can.
Right. So that is myself. So the objectives is...
you have to put it on the slideshow mode.
Let me just put on slideshow, yes. Yeah. Now, so the objectives is mainly to talk about the pathophysiology, and I think I didn't want to include this in the first term. I told Doctor I didn't want to include this, but I felt in hindsight, I was thinking, oh, let me put it, and I actually told him that I wouldn't have any slide. I'm sure he can confirm that, but I just had to work. I have had sleepless nights doing all of these things, but it's a good thing to be able to impart knowledge on others and for others to be able to learn a lot of things from my experience. So I'll talk basically about the pathophysiology, then we'll talk about how we diagnose type 2 diabetes and the various drug treatments that are available at the moment that are being used in the treatment of, in the management of type 2 diabetes. And what are the target glycemic controls that we look at. And I'll give us a brief clinical scenario. With that clinical scenario, I want it to be a two-way. I don't want it to be myself just talking about, just telling you the answers. I'm sure that during the course of this discussion, you might be able to pick on some of those things. And then we can discuss it together, and then we can arrive at what we eventually did for the particular patient. So I'll start. What is type 2 diabetes? Basically, type 2 diabetes is basically, it arises from, as we all know, beta cell dysfunction, relative lack of insulins, and insulin resistance. And insulin resistance is basically associated with those that are overweight or that are obese. And as you can see, the BMI, the normal BMI should be normally between 18.5 and 24.9. And the worrisome part of this as it progresses is that it can lead to micro and macrovascular complications, such as patient developing stroke, developing MI, having patient developing might lead to amputations, foot amputation, patient losing their sight. So that is why type 2 diabetes is a very, very serious disease. And as I mentioned earlier, pathophysiology, I'm sure we should be used to this. Relative lack of insulins, because as time progresses, in patients that develop type 2 diabetes, what you find out is that they are not able to produce more insulin as they used to. They still produce some, but they are not able to produce as much as they should. And then there'll be an increase in the level of glucagon, which then leads to more glucose being produced in the body. More glucose is also produced from the liver. Instead of it being stored, it's now more being produced because there is relative lack of insulins. And the other part of the problem is that there is insulin resistance because somebody is overweight, the level of insulin decreases, and then the body is not sensitive to the available amount of insulin in the body. And that is what leads to all the complications and what happens in type 2 diabetes. And I just wanted I'm not sure whether everybody can see this very important slide. This slide tells us basically how type 2 diabetes progresses and the complications that you can see with type 2 diabetes. I'm sorry, I think something is happening to my side of the slide here. Right, I'll put this here. 1 second, sorry, just trying to, right, I'll do it this way. So this graph basically depicts to us what actually happens in someone with type 2 diabetes, how it progresses. And the next slide, I'll tell us what impaired glucose tolerance actually means. It's basically at that point where is actually a line there where somebody who is like what we call pre-diabetes, before they actually fall into being diabetes. And I'll tell you what blood tests and the readings that we look at, the result that we look at in terms of how to interpret those results. I'll tell us in the next slide. And what happens in those with type 2 diabetes is, as you can see, is beta cell decline. There will be lower level of insulins, and then hepatic glucose, there is increase in hepatic glucose production, which is in the red ones, and then more glucose is then being produced. And as time goes on, what you then see is that there will be an increase in microvascular and macrovascular complications, as I mentioned earlier. So for us to be able to diagnose type 2 diabetes, there's something that we call pre-diabetes, but they don't actually use the term anymore. They now use what we call non-diabetes hyperglycemia. It's basically when you take a blood glucose, a capillary blood glucose, and you find out that the patient falls between the range of about 5.5 when they actually fasted overnight. And then when you take their blood glucose level and they fall within about 5.5 to 6.9, or there's something we call glycated hemoglobin, which is basically an hemoglobin level between an HB1AC level between 42 and 47. Or when we do what we call an oral glucose tolerance test, where the values fall between 7.8 and 11.1. Anyone with these values, you can classify them as being non-diabetes or non-diabetes hypoglycemia. They are basically pre-diabetes. They are likely to go into diabetes if nothing is done. So that is why those patients, we actually sit them down, advise them and tell them and give them advice about how they can prevent themselves into going into being diabetes. The glycated hemoglobin that I mentioned, this is a very crucial test that we run, especially for the diagnosis of type 2 diabetes. It's used for the diagnosis of type 2 diabetes, and it's actually also used for monitoring the control of type 1 and type 2 diabetes and other types of diabetes. We actually do this test within about 8 to 12 weeks when we are monitoring our patients, or especially patients that we are monitoring. It's a very, very good test. But for us to be able to diagnose diabetes, actually, I presently work in an acute setting, but at the same time, sometimes I work at GP practice. So, but for you to be able to diagnose type 2 diabetes, these are the values that you'll be looking for. An HbA1c level that's greater than 48. In someone who is, or a fasting blood glucose level of 7 or greater than 7, or when you perform an oral glucose tolerance test and you find out that it is greater than a blood glucose level greater than 11.1. If the patient does not present with any of these osmotic symptoms, which I call 40s, I'm not sure whether anyone has heard of what we call 40s. 40s are basically a patient will present with being thirsty, somebody who is tired, somebody who becomes thin, maybe they've lost a lot of water, and somebody who is, I've mentioned thirst, somebody who is thirsty, somebody who is tired, and then toilet. Toilet basically means that they have polyuria. So polyuria, polydipsia, tiredness, and then the patients they start losing weight. So when you have patients that present with such symptoms and one of these test results that falls within those range, you can classify them as having diabetes. Or if the patient does not have those symptoms, and then you run those tests, and then you find that 2 of the tests are positive that falls within those range, it means that the patient, you can classify that patient as being diabetes. Right, I've got a clinical scenario here, and I just want us to quickly look at this because this is what we'll be looking at. I'll just give us about 1 minute to quickly jot this down, and then because we'll be sharing this together, because I want us to really look at this patient and be able to decide what are we going to do for this patient. So I'll just give us 1 minute to look at this scenario. Does anyone know how to proceed with this patient? Right. These tables, I have actually got this table to make it easier for us to be able to understand the different types of medication that we use to manage. Okay, somebody has raised their hand. I think, just 1 second. Oh no, sorry. I think I've gone too back. What? Okay. Well, maybe when we get, I will allow that person to be able to share when we get somewhere. Maybe that person might be able to change whatever they are thinking of when we get further. So these are some of them. I'll go through some of the medication that we use to manage our patient. Metformin, very common, very cheap, very, very good. The pharmacology, I wouldn't tell us much about the pharmacology because as pharmacists, I would imagine that we will know more about all this pharmacology. Adverse effect, side effect of the medication, common side effect of metformin, gastrointestinal side effect. Lactic acidosis, especially when the patient has got renal impairment, patient that is very dehydrated. And that is the reason why you need to withhold metformin when the patient is going for surgery. And we need to we also need to be very careful in renal impairment. Generally, my advice is that when you are starting metformin for a patient, you need to go slow. You start maybe 500 milligram once a day, maybe for 1 week, and then you advise the patient. If the patient is able to tolerate that, the patient can then move up to 500 milligram BD and then gradually to 500 milligram TDS and then gradually like that. to the maximum tolerated dose for the patient. As I said earlier, advantages of metformin, very cheap, cost-effective. The good thing about metformin is that, especially except if it is contraindicated for our type 2 diabetes patient, it's actually a wonderful drug for our type 2 diabetes. But despite the fact that it's very cheap, it's very wonderful. It has the most important aspect of its usefulness is that it leads to weight loss, which is what we want for most of our type 2 diabetes patients, because what you find with most of the type 2 diabetes patients is that they are overweight. It also has some very good CVD benefits, that's cardiovascular disease benefits. And it's the only drug that you can actually use out of all the medication that I'm going to mention now, that you can actually use in pregnancy and breastfeeding. None of the other ones, you can't use any of the other ones. You can only use maybe insulin, but I will talk about insulin later on, if time permits me. Then the next one is sulfonylureas. I remember that when I was in, when I was still in Nigeria then, we used to use glycaemic. I'm thinking we don't use it anymore now. The one that is most favored now is the glycoside, because it's short-acting, although the most important side effect of sulfonylureas is hypoglycemia. And that has been mean is glycaemic is actually associated with more hypoglycemia in comparison to the glycoside and the glipizide. So that is why most clinicians favor the use of glycoside. But we have to be very careful with glycoside, with sulfonylureas, especially in someone who is overweight, and especially in our elderly patients, who can easily fall down because hypoglycemia could set in. And the other thing that we need to advise our patients is for the patient to take it with meal. That might reduce the hypoglycemia effect. It's also very cost effective and is a very brilliant drug when it comes to when you have a patient who has an acute hyperglycemia, especially a patient that comes into the hospital, they've never had type 2 diabetes before, and then they are diagnosed in the hospital, they suddenly have hyperglycemia, and then we diagnose them. We usually start them on glycoside because it does quickly bring down the blood glucose level in comparison to most of these other medication that I'll be talking about. Now, I'm not sure whether in Nigeria, whether we use this drug called pioglitazone, thiazolidinediones, we call them. And we don't generally, it's run out of favor in this country because of some of the adverse effects and the contraindications to its use. As you can see, it's contraindicated in somebody who has heart failure, somebody who has got bladder cancer, someone who has got edema because it also increases fracture risk. So that is it, and then it could also lead to macular edema. So there are so many problems with this medication. But the good thing is that it's very good when it comes to being used in renal in patient who has renal impairment. And I've seen some clinicians use it when they want to use a very cheap medication and they are looking at their patient. The patient is not really overweight. The pioglitazone is not contraindicated, so they likely use pioglitazone, but it's run out of favor. And it's also have low risk of hypoglycemia. The other medication that I'm not sure of, whether we still use whether we have it in Nigeria or whether it's common, I don't know. It's what I call it gliptins. It's an easy way to call it, gliptins. They are called the DPP inhibitors. And they are more similar to another type of medication that I will come to in a minute called the GLP-1 agonist. So they are more similar in their mechanism of action. And that is the reason why both of them should not actually be used together. But one of the downside of the gliptins is that the side effect is GI disturbances. Pancreatitis is a major problem, especially in patients who are alcoholic. So we need to be very careful when you want to start gliptins in such patients. The good thing is it's weight neutral. It has low risk of hypo. And there is one of them that is favored by one of my one of my clinicians, the linagliptin. Linagliptin, you can use it at any level of renal function. But the other types of gliptins, you have to adjust their dose when you have renal impairment. So in this, when you want to start gliptins, you need to be careful. You need to be looking out for signs of pancreatitis. The next type of medication is the SGLT2 inhibitors. I don't want to talk too much about their pharmacology, but in this case, I'll mention this particular one because of the way it works. It basically inhibits the renal absorption of glucose, which means the patient will be passing on a lot of glucose, and that is the reason why it has some of the side effects that it has. Because it's easier for yeast to actually grow in those conditions. And that is why one of the most prominent side effects of these SGLT2s is patients having yeast infections, UTI, urinary frequency, and it could also lead to hypovolemia because it draws up a lot of water. And that's why when somebody is not feeling well, or maybe somebody who is going in for surgery, or somebody who is acutely unwell, you need to stop the gliptins. And you need to be very careful with them when somebody is feeling is not very well. You probably might need to check to make sure that the patient does not have ketones in their blood, because once they have that, you just need to stop the SGLT2. And we need to avoid it in patient who has got diabetic foot disease, because they found out that it has a high risk of lower limb amputation. Correct hypovolemia, I think I mentioned that earlier. And make sure that the patient, when you stop it, especially when the patient is going in for surgery, or they're going in for a procedure, or they're unwell, when you want to restart it, make sure that the patient is able to eat and drink well. The patient is well hydrated before you restart it. The wonderful thing about the SGLT2 and the next one that I'll talk about is that they are very, very good when it comes to patients who has got cardiovascular problems, or patients who have got CKD. It's been shown that they lead to they improve secondary outcomes in patients with heart failures, or somebody who has got renal problems, or who is with CKD. The same thing applies to the GLP-1s inhibitors, agonists. The GLP-1s are actually injectable products. So that is one downside of them. They are injectable products, and as we all know, I don't know whether any one of us would like to be injected from time to time. So that is the one downside of the GLP-1s, but they are brilliant. They have very good CVD profiles, and then CKD profile. And then they can very be used in so many levels of liver impairment. Although these two medications are very expensive, so it might be unavailable in this part of the world, especially in UK. We have the health service, so we don't actually pay for those medications. So it's people prescribe them, but not generally the GLP-1. There are restrictions on how you can prescribe them, and most especially the GLP-1s. There are restrictions on what is allowed and what is not allowed. The patient needs to have, for instance, GLP-1s. The NICE guidance allows that the patient, you can only prescribe for patient who has a BMI of greater than 35. But there are other reasons as well where you can prescribe a GLP-1. But as I said earlier, you shouldn't prescribe it with the gliptins, because they are more or less, if you look at their mechanism of action, is more or less the same thing. One downside of it is that you shouldn't use it like this. You can see it exactly the same thing like the GLP-1s. Pancreatitis again. One downside is GI side effect is very prominent, but I always advise patients that are started that we start on GLP-1s to be mindful of this side effect, and then as time goes on, the patient gets used to that side effect, and then it does go away. But the good thing about it is that it leads to weight loss, and this is what we need for our diabetes, for type 2 diabetes patients. I'm not sure whether, oh no, it's not going forward. All right, I've also got this table. This might make it easier for us to be able to understand the doses that we can prescribe for our patients, depending on their kidney functions. So as you can see, for instance, GLP-1s, you don't actually need to adjust the doses at all. The one downside of them, the one downside is the fact that they are injectable medication. But the good side is that there are some of them that can actually be given weekly. So it makes it convenient for the patient. The SGLT2, there is a new data that just came in about the canagliflozin, just about, it's about a month or a month and a half ago. And that's why I've changed this slide slightly, because the slide was not like this before. So for the canagliflozin, there was a new data that just came in that canagliflozin can now be used in patients who has got poor renal function. Unlike the other SGLT2, the DAPA and the EMPA. That's how we call them. So I'll go on to the next slide. I just want to give us a few minutes because we are going to be able, we are going to use this for our scenario. So I want people to be able to pick us on this particular slide, because we are going to use it in our next scenario, in our scenario that I have. So I'll just give us maybe 30 seconds to quickly look at this. Right, I move on. There are two medications that I have not mentioned. Alpha glucosidase inhibitors, we don't use them because they are not that effective. They are effective slightly, but they are not with what we need for our patient. They are not that effective. The meglitinide as well, they run out of favor. They are not really very, they more or less behave the same way as the sulfonylureas. So, but they are out of favor now. Nobody uses them anymore. There was a time they came in and they were used for some few years, and after a while, people start seeing so many of the side effects, and then in terms of some other benefit, the cardiovascular benefit and all the other benefits, it was not there, so they had to just be abandoned. But I still leave them on that slide so that people will know those other medications that we use for type 2 diabetes. Right, I mentioned something about the SGLT2. So this is something that just came in not long ago. About I think a month and a half ago. The dapagliflozin or empagliflozin are not to be initiated in patients who has eGFR of less than 60. But Cana can now be used. So this just came in. Canagliflozin can be used at this level, and it can actually be continued for patients who are already on it, even if their eGFR drops below 30. And that's one good thing about the canagliflozin, aside the CFD benefit and the CKD benefit and the other benefits. Right. What are we looking at? What are the targets for the control of type 2 diabetes? I think the goal of treatment for us is to prevent complications. As I said earlier in the diagram that I showed about the progression of diabetes, it will eventually lead to, if there is no proper glycemic control, then it will lead to all these complications. So, but we want to prevent that from happening and to improve the quality of life of our patient. So we should take an holistic approach to manage our patient. So the most important thing is our lifestyle changes. Address our patient on diet, on exercise, on stopping smoking. We have smoking cessation service that we provide here, because smoking actually increases the risk of somebody who is not diabetic, who is going to go into diabetes, who is going to likely have diabetes. Weight reduction, being overweight, being obese, will also increases the risk of you having diabetes, and it also reduces the control of glycemia as well. And then we also need to be mindful of the alcohol intake the patient needs to be mindful of the alcohol intake. We have there is a limit that has been set for female. They can have about 14 units of alcohol in a week, and for male is about 21 units of alcohol in a week. So we should advise our patients to keep to those limits for those patients that drink. But before we start any treatment, there are certain things that we need to look at, our patient key characteristics. We need to look at the patient comorbidities, other things that the patient has aside the diabetes. But because, as I've said earlier, there are some of these medications that really helps with alleviating some of these problems. We need to look at polypharmacy issues. I'm not going to dwell too much on that because that's our area. Lifestyle changes. What are the other things we need to look at? The age of the patient. Do you want to give a frail elderly patient something like that could cause hypoglycemia, something like sulfonylureas? You need to look at the target HbA1c is individualized for our patients. You need to look at renal function, look at the liver function profile, look at, especially when a patient comes acutely into the hospitals, look at the signs and the symptoms, look at the symptoms that they are presenting with. You need to look at their lipid profile because that also needs to be managed. And then you also need to look at blood pressure. For type 2 diabetes patient, you need to manage that as well. Someone who has got CKD, you need to, their target is different from somebody who does not have a CKD. And then we also need to look at, because as I said earlier, it's an holistic approach, the side effect profile of the drugs. Is the patient going to be able to adhere to treatment? Because if the patient does not actually want that treatment, you cannot actually force it on the patient. So we need to be able to bring the patient to our side. And generally, we tend to really start anti-diabetes treatment after we explored advising the patient to manage their lifestyle, to put in some lifestyle changes. If things don't work, and then the HbA1c consistently is above 48 millimole per mole, then we then need to start thinking about starting treatment for those patients. But for some of the patients who present acutely in hospitals, we need to start treatment straight away. And then for most of our diabetes patients who are not frail elderly, who does not have very bad kidney or very bad liver function, or who does not have end-stage renal disease, the target for most of these patients are usually 48 to 58 millimole per mole. If it's easy for you to use the 6.5% to 7.5%, fine. I think in America they use the percentage, they don't use the millimole per mole. So, but we set higher level for those patients who have got all these other problems. And we generally aim for a tight blood glucose control. But one thing about type 2 diabetes is that they don't actually need to monitor their blood glucose at home. They don't actually need to do that. HbA1c level is the best thing that is sufficient to be able to, because HbA1c is enabled to be able to see the glycemic control over the previous 2 to 3 months. But for those people who work in hospital, this might be relevant to you. So if you are treating a patient in the hospital and you want to actually know what range of blood glucose level you should be looking at, this is relevant to that setting. Except for our insulin patients, where we then have to give them a blood glucose meter and they have to then monitor their blood glucose level. But we need to relax this blood glucose level, especially in those categories of patients, our frail elderly patients, patients who are palliative, patients who are at end of life, patients who are on dialysis or who have got poor liver function. So we usually relax their blood glucose level for them. But those are some of the things that we need to check before we start a patient on any of this medication. Right, coming back to our scenario, how do we proceed? I think I've given us some clue now. How do we proceed? So if anyone has any, if you want to ask a question or contribute, you have been enabled to unmute yourself, please. You can unmute yourself. If you have any question I want to call, just raise your hand and then unmute yourself. We'll call you. Because I think this should be an interactive session. Yeah. I think it should be interactive because I think that might be the so that we can be able to. Please, if you have questions, kindly unmute yourself and proceed, please. So this is our patient. Pharmacist Ame, you raise your hand the other time. Please, can you go ahead and ask your question? Pharmacist Ame, you have been unable to unmute yourself, please.
Hello, sir.
Yes, go ahead, please. Can you go ahead? I think Pharmacist Rahman, can you go ahead so that maybe at the end of the meeting? Yes. Right. Because I'm going to, as we say in Nigeria, I want to. If I go ahead, I'm going to give you the orijo. So I don't want to. I don't want to give you the orijo. So if I go ahead now, if anybody knows how we can proceed with this patient, I've mentioned some medications. Or maybe should I go back? Should I go back to those medications and maybe you can then maybe that might help.
For Mr. Rahman, please. Yeah, in the medication code, if you look at the history.
Hello, I raised my hand.
Please go ahead, please. Go ahead, please.
I raised my hand. Nobody.
Okay, kindly go ahead.
Good evening.
Good evening. Yeah.
Wonderful presentation there. I'm Dr. Danjuma from Lafia. That's
okay. Welcome.
Sorry, the last slides there. You're talking about when you see when you are talking of clinical, then I could see some like age is coming in there.
Yes.
And no, the slide before the last, I think.
I think it's this one.
No, not this one.
Is this one?
No, just go forward.
This one I said clinical characteristics.
The last one before the scenario.
Yeah, that's the one. That's the one there. Hello.
Okay.
That is why I've said
hello?
Clinical. Maybe I should move my. I don't know whether you can see my cursor.
Hello.
Around there, yes.
No, not this one.
Which one? Should I go backward?
Okay, you can continue. When you are done, then we'll talk about that, because my own is coming out. The question I'm trying to raise is.
Okay, I'll call on the Dr. Polycarp, please. You can ask a question. Dr. Polycarp. Dr. Polycarp.
Is there anyone that can be able to tackle this scenario?
Somebody says in your hand, Dr. Polycarp, please. Dr. Polycarp. Hello, Dr. Polycarp. Okay, maybe Pharmacist Ibrahim.
Should I move on?
Okay. Move on, please. Move on.
Right. Okay. Right. Okay. Now, so for me, this patient, if you look at this patient, there are we do have what we call guidelines that are widely used. Here in the UK, I'm sure some people will be conversant with what we call NICE. So NICE developed so many guidelines. There is a NICE guideline, but there are other guidelines that have also been developed. We have the ADA and EASD guideline. I tend to agree more with the ADA and EASD guideline. The NICE guideline for type 2 diabetes now is of old age. It is, I think the last time it was updated was 2000 and is that 2016 or 2012 or so. So it's basically in a way outdated in a way, because there are so many medications that have come into the pipeline after the issue of that guideline. And so many of those medications are those medications that I've mentioned at the end of this slide, like the GLP-1s and the SGLT2s, although they have embedded them in some other part of the guideline, of the NICE guideline. But these two medications have actually shown a lot of wonderful benefits, especially for patients who have got cardiovascular diseases, atherosclerosis, cardiovascular diseases, or these patients who have got heart failure, or those patients who have got CKD. They have shown brilliant promise for those patients. And when you look at the current ADA guideline, which I'm going to share with us in a minute, you will align with the fact that this patient should be treated with the choice of medication that we eventually prescribe for this patient anyway. So these are the treatment options that we have. The patient is already on metformin, right? So the metformin seems not to be doing anything. It's doing something else. So when I speak to the patient told me, oh, he's actually been complying with metformin. So compliance is not an issue. The patient has been taking their medication all the time. But what has been an issue is that with diabetes, it tends to progress, especially in somebody who is not losing weight. As you can see, the BMI of this patient is 32. This patient still smokes. This patient still drinks a lot. I'm not sure if I go back to the scenario, right? This patient still drinks a lot, right? So the patient has not made adjustment to their lifestyle, which is very crucial. So that for me is the starting point, right? Now, the HbA1c level is high for this patient, is very high. And considering the age, the patient is 48 years old, it's high. But we also need to consider their kidney function. We need to consider their liver function. We need to also consider their blood pressure. And we also need to be looking at their lipid profile, because that is also important in terms of complications, microvascular complications. So all this needs to be tackled. And we have to be mindful of the fact that this patient has got heart failure. And this patient has got hypertension and is not being controlled. So what do we do? So for this patient is tolerant of metformin, is on metformin. So there are two main options. So the next line is to actually add another medication, which is what we call dual therapy. And those are the combinations that we can use. So which of those combinations should we use? Does anybody know which combination we should use? I think it's better
to go ahead because they are muted.
Right, okay. Now, if you look at the case of this patient, we are going into dual therapy now. The patient is only on metformin. The patient is using the metformin. Should we stop the metformin? Does anybody think we should stop the metformin? I don't think we should stop the metformin because renal function is okay. If you look at this particular, if you look here, the maximum dose of metformin is 2 grams a day if the renal function is within that range. So I've come back and said, this is why I said this graph will be very useful for us. So coming back, so this patient can still have 2 grams of metformin in a day, as long as it's not contraindicated, as long as there are no other factors that stop us from giving this patient the metformin. And I've said the advantage of metformin in our patients, especially type 2 diabetes patient, this particular patient is overweight. So the metformin will help with weight loss. Okay, so that's one good thing about metformin for us to keep the metformin. Should we add sulfonylureas? Does anybody think we should add sulfonylureas? Although it's cheap, but should we add it? I don't think so. The reason being that what sulfonylureas does increase weight. So that's one downfall of sulfonylurea. But there are certain cases where, as I said earlier, that we do use sulfonylureas, especially when you have somebody being admitted into the hospital and they have hyperglycemia. They are type 2 diabetes, they are already on metformin, but suddenly they feel ill, they fell ill, and they come into the hospital, they have acute hyperglycemia. So it's better to just start them. Glycoside is likely to bring down their blood glucose level as quickly as possible. That's one good thing about it. But your downside of it is that weight gain is one downside of it, especially in somebody like this who is already overweight. So for me, it's not, we should leave it aside. The next one is pioglitazone. Can we use pioglitazone? Absolutely not. This patient has got heart failure. So we can't use pioglitazone. So can you see how I have been taking off all the medications gradually? So now we are coming to the next one now. Where's my patient? Now, the next thing is, the patient as okay. This is how I've managed to look at the patient. I mentioned the weight. HB1AC target for this patient should be between 6.5 and 7.5%. That is where we want to get the patient to. The patient is about now at the moment the patient is 8 point something, 8.2%. But we want to get the patient down to 7.5%, lower than 7.5%. And we need to also be mindful of the fact that we need to be thinking about the heart failure. So those are some of the things. We need to look for medications that can actually help us with the heart failure. So, and we also need to look at other things as well. So this is the ADA or ASD guideline. And this guideline is actually, if you look at it, I've actually circled this part of the guideline. Why did I? So, and this is what made me to narrow it down to these two medications. So I've narrowed it down to these two categories of medications, the SGLT2s inhibitors and the GLP-1s, because of their cardiovascular benefit. And because of the fact that one of them is actually very good in patients because of the CKD benefit as well, especially with the SGLT2. So it made me to narrow it down to two categories of medication now. So that is a starting point. So I have taken off about, how many have I taken off now? About 3 or 4 medications. So I've narrowed it down to 2 now. So where do we go from here? So the next thing to do is to see which one of them will the patient likely to have. If you speak to your patient, most patients don't actually like anything injectable. And especially in the health service that I work in, they wouldn't advise you to start a patient on GLP-1s generally because it's even more expensive. Although it has its own beneficial effect. But at the same time, the SGLT2, when we look at our patient, you'll find that the patient has got heart failure and CKD. So the SGLT2 is much more preferable in this kind of patient. But so now we have chosen SGLT2. So which of the SGLT2 should we go for? That's another question. So, and that is easily, and that we can easily get that answer if we look back at our patients and if we look back at the kidney function. The kidney function is what? The eGFR is 56. So out of all the 3 SGLT2 that I've mentioned, which one can we use? I think I've mentioned 3 of them. I've mentioned DAPA, I've mentioned EMPA, I've mentioned CANA. Can you see now how I've narrowed down everything? So for me, for this patient, I had to use canagliflozin because it's the only one that can be used at that level of kidney function. Except if it is contraindicated for whatever reasons. And then the other thing is that this patient has got heart failure. It will be beneficial to the patient in the sense that it will bring down it causes what? Hypovolemia. What do you need for somebody who has got heart failure? Usually it's likely that there will be odematous. So it has a very good benefit for somebody who has got heart failure. And it also has good benefit because of the fact that the patient has got CKD. And when you look at this patient as well, when you look at this patient, where's the patient now? There's something we call urine ACR, urine albumin creatinine ratio. Is moderate, there is a moderate increase. This patient kidney is getting worse. When I look at the trend of this patient from the last time that the patient was assessed and the present time, we found out that it's getting worse. So what medication can help to reverse that? So that is the choice. That is why we went for the SGLT2. And canagliflozin will serve this patient very well. And also, it's also very good. It will also lead to weight loss as well. Because if you look at this slide that I've shown you, if you look at the other part of this slide, when it comes to, let me just, I want to show everyone something here. If you look at this slide, I'll go back to that slide. This is the expanded part of the slide that I cycled. But it's now, it is the expanded part of this, or I'm not sure if everybody can see this now. This might make it more clearer. And if you look at the weight benefit, if you want to minimize weight gain or promote weight loss, so the GLP-1 and the SGLT2 are preferable because they lead to weight loss, like metformin. In fact, the GLP, one of the GLP-1 is now licensed in somebody, in patients that are very overweight. It's called liraglutide. It's licensed for patients who are overweight or obese, but there are certain conditions that has to be met before you can prescribe it in the NHS. Okay, so that's the good thing about the GLP-1s. If cost, generally, this might be applicable, especially in situations in countries like Nigeria. If you are looking mainly at cost, you are not looking at all the other benefits of treatment for your patient. So we might be looking at it this way. Okay, I'll just use this one. But even if you want to do this, if you want to follow this slide, if you want to use this one, you won't be able to use this the thiazolidine with the pioglitazone, which is thiazolidinedione. The sulfonylureas, you may not want to consider it as well because of what I mentioned, weight gain, right? So what are the things that we can do for our patient? These are some of the things. This is how we arrive at choosing a particular product for our patient. Now, I think I've answered the question by saying, okay, this is what I did by narrowing things down. This is exactly what we did. The reason why, part of the reason why I didn't choose the gliptins, this patient is alcoholic. And one of the things that we find with most of our alcoholic patients is that usually when they're alcoholic, as we saw in, if you look at this patient scenario, you will see that that patient has got moderate liver impairment. So we are usually very careful, especially in patients who are alcoholic, who are drinking a lot of alcohol. We are usually very careful with them, starting them on gliptins. We are not sure sometimes whether the patient may have pancreatitis or not. So we are usually very careful. Well, we can check that if you want to check that, especially if the patient is in the hospital setting. We can actually set order for amylase level test. We can check that to actually see whether this patient has got an pancreatitis or not. Or we could check, we could do a fecal elastase test. And that is the reason why I've chosen canagliflozin for this patient at a dose of 100 milligrams a day. So this is the ongoing monitoring that we do for all our patients. HB1AC, we've set our target for the patient, 6.5% to 7.5%. Because that's a very good one for most of our patients. We need to do full lipid profile. We need to do it every 3 months. All of this usually needs to be done every 3 months. When a patient comes into the clinic for their review, you also have to look at their they need to be sent yearly for eye examination. They need to be sent for foot examination. So total cholesterol level should usually be 5 or below. Normally 4, I would say 4 or below. Blood pressure, I was mentioning something about blood pressure earlier. We do it when the patient comes into the clinic. For patients that are less than 80 years old, especially in the case of our patient, these are patients, the target for these are patients because it's got CKD is 130/80. That's our target. And you will see what I did when it comes to managing the blood pressure at the end of the day. And we also need to look at this urine albumin ratio, urine albumin creatinine ratio, kidney function test, liver function test. We do their full blood count, we do their U&Es, we look at their weight, we check their weight when they come into the clinic. This is the optimum weight that we are looking for even those that are not diabetes, including yourself and myself. Should be the optimum weight in order to prevent the development of diabetes. Smoking status. This patient is a smoker. So this patient was actually, after so much deliberation, the patient agreed to go for a stop smoking service. Eye examination, I think I mentioned that. We also screen their food for any development of neuropathy. And then patients that have type 2 diabetes, they also have sexual health problems. We see some of them that are on sildenafil. They are prescribed sildenafil. So we also look at their sexual health as well. As I mentioned earlier, SMBG basically means self-monitoring of blood glucose is not recommended for those patients who are type 2 diabetes, especially except if the patient is on insulin. So for me, the way to go about all these things is the patient. Things should be individualized for the patient. Speak to your patient. Because at the end of the day, the patient is at the cornerstone of everything that we want to do. If the patient does not agree with whatever treatment you want to give them, it's never going to lead to optimum outcome. So at the end of the day, because of the high blood pressure, the ramipril had to be increased to 6.25 milligram a day. And the good thing about ramipril is also prevent development of nephropathy. That's one good thing about ramipril. And I'm not sure whether anyone knows what I mean by CCB. CCB basically calcium channel blockers. We do actually advise the use of calcium channel blockers in patients who has got cardiac heart failure. We then had to increase the dose of atorvastatin because of the lipid profile that was increased. Lifestyle advice was given to the patient. And then we have to look at the compliance issues. You know, I mentioned the problem side effects of canagliflozins. You need to let the patient know some of these problems right from the word go, so that the patient, when the patient starts experiencing some of these side effects, they will not just suddenly stop the medication. You need to advise them about when they fall ill, what they need to do to stop the canagliflozin, especially when they are not eating and drinking properly. When they are going in for surgery, they need to stop their SGLT2. And things like metformin as well, when they feel really bad, when they are not feeling well. So in conclusion, I think the most important thing for our type 2 diabetes patients is education, because they have to be the one that will manage their condition. We cannot force things on them. We cannot force anything on them. They have to be the one to do everything. If they don't accept there are always ways, there are so many options for them that we can choose from. Some patients would not want to have, some patients would not agree with having injectable medications. Some patients are happy with injectable medications. So it depends, it really depends on the patient. So thank you.
So I want to thank Pharmacist Ibrahim for that wonderful and great lecture, very educative, very detailed, and very thorough. Next on the agenda is questions, contributions, and comments. Pharmacist Ibrahim, can you please stop your slide? Can you stop sharing your slide for a while?
That's it.
The floor is now open for comments, contributions. So you have been enabled to unmute yourself, but kindly raise up your hand if you have any comment or question. Please raise up your hand so that we can see you. Okay, Pharmacist Kamal. Kamal, please go ahead, unmute yourself and go ahead, please.
Good afternoon. Good evening, everybody.
Good.
I want to appreciate the presenter, and I think it's a wonderful presentation. I have an opportunity to also increase our value with some of the recently used anti-diabetes drugs. I'm well in line with the presenter. I just want to observe the issue at the point of the follow-up management. The patient presented before us is already a comorbid patient, has diabetes and hypertension. I'm wondering, and I'm still wondering, the duration of 3 months for follow-up checkup BP, even though the patient has been placed on the antihypertensive drug, that's Ramipri, with the increased dose as suggested by the presenter. But I'm wondering, for keeping the patient for so long, up to 3 months, before we now review some of these parameters which are very key. For, as he said, our main goal here is to prevent such complications that will arise from the either diabetes or hypertension. In these scenarios, now we have multiple complications that are anticipated to come off if not properly checked up. I am of the view as a clinical pharmacist that such follow-up parameter checkup should be so more frequent and so presented. Thank you very much.
Thank you, Pharmacist Kamal. Pharmacist Ibrahim, can you respond to that?
So what is the question? Sorry, I didn't catch the question. I thought it was just making a contribution.
The follow-up plan, such as BP and other that has been arranged to be at least 3 months. Your presentation shows that it should be at least 3 months, I think, and above for BP checkup follow-up. I said I am of the view that it should be more frequent than that. The period of
okay.
The nature of the patient.
All right, right. So generally, so you see, the presentation is not. It's just to show us what actually happens sometimes. With this sort of patient, with this particular patient, it's not that the patient. The slide that I showed. Where is it now? Let me just go back to the slide. Just 1 second. I want to go back to the slide where. Right. I'll just share this slide again. But I just want to share this slide again, this particular. Oh no. Where is it now? Right. Right.
Good.
Now, this is generally what is done for most patients that are stable. For a patient that is not stable, you can always bring them back, even if you want to bring them back in about, especially for patients who you are trying to control the blood pressure. You can bring the patient back. If you want the patient to come back in about 2 weeks, you can bring the patient back. If you want the patient to come back in about a week's time, you can bring the patient back. But this, we call it in this part of the country, we call it 9 care processes, right? So, but this is what is looked at for most patients that are very stable. As you can see, the HB1AC, you can't even do HB1AC. You can't do HB1AC in a week's time. It's of no use. Because HB1AC is only of benefit if you use it in about 2 or 3 months' time because of the way HB1AC is. But for blood pressure, you can actually follow the patient up. You can say to the patient, oh, please come back. You can actually, sometimes you can tell the patient, oh, can you buy a blood pressure machine? I'm going to increase your blood pressure medication. Can you buy a blood pressure machine? Do the recordings at home. I want to see you in a week's time. And then it comes back, or if you're not feeling well, if you're having these symptoms, please just ring me back. And then the patient will do that. But what I put here is basically for us to be able to know what we do for ongoing monitoring of our patient. It's a general thing. It's not just specific to that patient. As you can see, I didn't even mention anything about what I would do next in terms of blood pressure monitoring for that patient. I just said, oh, I increased this is what I did. I didn't say, oh, the patient will come back in 1 week or 2 weeks or so. But actually for that particular patient, we asked the patient to come back, to contact us, to let us know what has happened, so that at least we can then optimize the what do you call it, the blood pressure medication again. And the blood pressure medication could actually be increased higher than that. The reason why we didn't increase it is basically because of the fact that this patient has been put on the canagliflozin. And we felt that what we have seen in most of our patients that are put on SGLT2 is that usually most of them, their blood pressure usually, because of the way canagliflozin works on the heart, usually in patients who has got heart failure, what we have seen is that it could probably drop the blood pressure as well. It has a very good CVD benefit. So I could have increased the patient dose about 7.5 milligram. But because of the fact that I was thinking, oh, this patient, if I increase it too high, then the patient may suddenly go into what? My suddenly be falling down. So I don't want that to happen. So you have to balance everything up. So this patient will actually has to come back in about 2 weeks' time. But if anything happens between that time, then the patient can actually come back earlier than that. So, but this process is there. It's just for everybody to see what we do for regular reviews of our stable patients. I hope that is clear.
Thank you, Pharmacist Ibrahim. Next is Pharmacist Ahmed. Pharmacist Ahmed, you raise up your hand. Can you go ahead, unmute yourself, and make a connection?
Thank you very much for Ibrahim. What a great presentation. My question borders on the role of the clinical pharmacist in looking at the non-pharmacological aspects in terms of the advice you need to give to the patient. We know definitely the patient is overweight. Did we try to look at the patient diet, or are we working in collaboration with the dietitian to ensure that the patient cut down on the weight? Then I'm also looking at what about the possibility of bariatric surgery in this case, because you know there's little you can really do to push the patient because you already have failure. So if you have to start introducing exercise, you can only introduce strenuous exercise that will make the patient lose weight. So what about issues of bariatric surgery? You guys didn't think about that? I mean, so that things that will reduce the weight as much as fast as possible, at the same time that will not have a overbearing effect on the heart. Thank you.
Right. In terms of bariatric surgery,
Yes.
this part of the world that I am in, there are certain, even with all these medications, if you have to prescribe something like the GLP-1s, you have to have very concrete reasons for you to prescribe it, right? Because things are really, really restricted.
Okay.
Right, because everything is the NHS. You are not directly paying for the care. You are not paying. It's not like America. So if you're in America or maybe in Nigeria, if you have the money, you can go and spend your money and then do your bariatric surgery. But over here, those people that are sent for bariatric surgery, they have to meet certain conditions. So for this kind of patient, this patient is 48 years old. And most times what you find out is that this patient, I was able to actually convince sometimes some of these patients, you are able to convince them by telling them certain things that in a way you are not trying to scare them, but you are trying to make them understand that if they don't do this, this is what is going to happen. This is what is going to happen. And as you can see, you can then show them the result of their previous results from when the inception of when the diabetes happened up to the present day. How the diabetes have progressed over time. So when you show them those things, and then you can also use things like, oh, this patient has actually got 2 kids. Does the patient want to die at a very young age or have all these complications and not being able to be with their family? So some of those things are things that you can actually use that will help that could motivate the patient to change their lifestyle. Most of the times, most of these patients can actually do these things, but sometimes people are reluctant. People are not aware of many things until you show them those things. Right? So this particular patient was able to be convinced. There are so many things there are so many leaflets that was given to the patient. And the patient was actually referred to a dietitian as well to be able to give more advice about how to manage in terms of diet. There are many other dietary options. for so many of our patients. You can ask them, somebody who is eating the white bread, you can ask them to change to a wheat bread. Somebody who is eating, who eats a lot of red meat, right? There are many options to eat lean meat. So many of them do not actually know, or maybe they've been given those information, they were not abiding, they felt that, oh, it's not going to progress. But when reality downs on some patients, they realize, oh, they need to make these changes, right? So
now is Pharmacist Raymond, please. Pharmacist Raymond.
Yeah.
What was the other part of the question? I didn't get the other part of the question.
The teaching is very good, but I'm still sleeping. Also,
Raymond, go ahead. Pharmacist Raymond, can you go ahead and answer your question?
Okay, thank you very much. Hello?
I'm listening, yeah.
Can you hear me?
Yes, we can hear you. Yes, go ahead.
Greetings to everybody. And I want to present a very well this evening. Very educative and very incisive. My question is about the monitoring of the parameters and progress of the patient. The presenter told us that it's not advisable to do blood glucose monitor. But that is the hallmark of our monitoring parameter practice here. Most of our clients have glucometer, the blood glucose monitoring machines, even the ones they use at home. And we find it working very well here. And he talked about one HB1AC, HB1AC rather.
HB1AC.
What? HB1AC.
HB1AC,
so,
yes.
And he told us that he can't even repeat, can't even do it within 1 week. So my concern now is coming to practice in the resource setting like Nigeria. Can't we still continue using the blood glucose monitor, even the ones the patient do at home, and the pharmacist help to interpret it for them and even get them to do it properly? That's the concern I have. Thank you very much.
Okay, right. In answer to that, see, things as pharmacists, we are scientists. We are scientists. We most of the things that, like for instance, the monitoring of blood glucose level is not scientifically proven that it's not usually really, you can't actually see the effect generally of those medications. If you are monitoring it, especially for our type 2 diabetes patient, because it's unlike insulin. It's unlike insulin. You wouldn't see the immediate effect. I mentioned one particular medication earlier. The one that you are likely to see the immediate, maybe within about 2 or 3 days, is usually the glycoside, because of the way it works. And because of what? Because it causes hypo, it drops down blood glucose level. It drops it down. It behaves more like insulin, because what is it? It's an insulin secretagogue, we call it. It makes the pancreas, it squeezes the pancreas to secrete more insulin. That is the way it works. But for some of our patients over here, especially those our elderly patients who are at risk of hypoglycemia, we usually give them, they are usually given blood glucose meters. But in general use, for most patients, they don't usually give it to them, because scientifically it has been found out that it doesn't really, in the short to medium term, it doesn't really show you much. You might see the result. If you want to see the result, maybe in about maybe 2 weeks or 3 weeks or so, you could do it, but you might not really, the overall use of it is not really tenable scientifically. I'm talking scientifically now. That is why it has been dropped in this part of the world. That's why they don't usually give it to all type 2 diabetes patients. But for our type 1, obviously, we have to use insulin. And for those patients, type 2 diabetes patients that are using insulin, and for some that uses sulfonylureas like the glycoside, we give them blood glucose meters as well. And for some our patients that are especially in the hospital, when they come into the hospital and they are diagnosed, when they have acute hyperglycemia and they are diagnosed within the hospital setting, sometimes we tend to give them the blood glucose meter, especially those ones that we start on glycoside. So that is when we usually give out the blood glucose meter. But generally, you can read more about it. You can Google it, and you find out that generally in most places they don't usually use it anymore. But in Nigeria, I'm not going to say you should stop doing it. If it's what you have been doing, then obviously continue doing it.
Thank you very much, Ibrahim. The next is Dr. Adela Ayeni.
Dr. Bello.
Okay.
Dr. Bello.
Yes, can you go ahead?
I have a question, Dr.
Please go
Bello.
ahead, Dr. Williams. Please go ahead. Or me yourself and ask your question.
Yes. I want to find out from I want to find out from the presenter. Thank you, Dr. Ibrahim Rahman, for that beautiful presentation.
There's something I'm missing.
The thing that comes to my mind is that did you consider the cost of medication?
Yes, that was what I'm about to ask.
Can you hear me?
Hello, yes, I'm listening.
That's exactly my question.
Cost of
that bringing all this home, considering a patient that has the same scenario in Nigeria.
Can I finish, please? Dr. Williams has the floor.
I was called first.
I was recognized.
Okay, go ahead.
Yeah. In view of the economy of today, I feel one of the key considerations for proper management of patients is affordability of the medication.
Yes.
Which will definitely affect the adherence of the patients to the medication. So what's your take on this? The cost
I think okay. I think maybe you may, I don't know whether you may have come, I'm not sure whether you looked at the whole presentation. There was a section that I mentioned. Let me go back to my slide. I'll go back to it. I'll share this slide with you, and I'm not sure whether, one second, I want to share this slide. Right, I'm not sure whether you can see this slide, Dr. Williams.
Yes, I saw it very well. I followed you from the beginning to the end.
Yes, so as I said earlier, so if you are considering costs, you see this part of the, when I was doing the presentation, I mentioned for places like where they cannot afford things, you can look at sulfonylureas in this particular situation. Generally, sulfonylureas will be the second. So is somebody else talking like that?
I think it's a distraction.
Okay, sorry. Right. So sulfonylureas will normally, for most of our patients, the one thing that we have to take into consideration is that we need to look at so many factors. We need to look at so many factors when we are dealing with our patient. It's not only about the cost. If the patient can afford it, then that option that I have enumerated will be a very important, will be a very good option, especially when you look at the outcomes. In this part of the world, the patient does not have to pay for it. In this part of the world, because it's funded by the NHS.
NHS, okay.
Yeah, it's funded by the NHS. It's funded by the NHS. The National Health Service funds everything. Although the money comes from all of us, but it's funded by the NHS. You don't have to pay for any sort of treatment. Right. So for this part of the world, we have to look at the clinical need. But at the same time, as I said earlier, when somebody said something about bariatric surgery, why I then mentioned that for the GLP-1s, for instance, although it's a wonderful drug, the GLP-1s is a wonderful drug, reduces weight, helps with the cardiovascular outcome is wonderful, CKD is wonderful. So for one will have tended to go for the GLP-1s, but the GLP-1 is one, injectable. If a patient even wants it, there is a restriction. There are certain conditions that has to be met. When it comes to NICE guideline has told us this is what has to be met by the patient before you can prescribe it. right? And basically why they've done, the reason why they've done that is basically because of the cost, right? So in the same thing with the SGLT2. It seems somebody is talking, I don't know.
Dr. Ike, can you mute others so that there is minimum interference? Dr. Ike.
Okay, right, I can talk now. Right, so what I'm basically saying is that based on, if you look at the cost of the medication alone, we don't look at the other comorbidities, and we are not looking at the other problem that this patient is obese already. It's already 32 kilogram per meter square, If you want to add on in sulfonylureas, which is a very cheap product, which is likely to also bring down the HB1AC level and the blood glucose level, very good. But on the other side, the other part of it is that this patient, you've given all this lifestyle advice, this patient may not really comply with those. And this is what we see day in, day out, especially with patients on this side of the continent. So you are trying to look at an agent that you can give to the patient that will help with the weight loss, and at the same time that will help with their that will lead to a good cardiovascular outcome as well as CKD outcomes. So you have to look at all of these things. But obviously in a place like Nigeria, you might want to go for sulfonylurea. You may want to go for that. Fine, it's good. It's good to go for something like that. But at the same time, you need to look at all the other things that I've just mentioned. Do you want the patient to put on more weight? If the patient puts on more weight, at the end of the day, you then have to go on up to the triple therapy. Because the problem with most type 2 diabetes patients is insulin resistance due to being overweight. So it's about balancing all the clinical situation that you find yourself in. So which one will you choose? And for me, on this side of the continent, that is what I will go for. On the other side, in Nigeria, you might go for sulfonylureas, but I will just say that you need to consider all the other things that I've just mentioned. So if the patient cannot afford what I've mentioned, then sulfonylureas might be one of the way out. But I bet you that the patient will come back in a few months' time, and the patient is likely to be needing another addition of medication, and that will add on more cost.
Thank you, Pharmacist Ibrahim. Now I want to call on Dr. Adiola to go ahead and ask some questions. Dr. Adiola, can you unmute yourself?
Thank you, Dr. Ibrahim. The question I was about to ask was related to Dr. Williams' question.
Okay.
About affordability of all these medications. Another thing I would like to talk about is the availability, the drugs being made available. Coming back to Nigeria, coming home to Nigeria. Are these drugs available? Sometimes the prescribers write these medications, but visiting almost all the pharmacists, they realize that the drugs are not available. Then usually NHS is not working in this part of the world. How do we assist such patients? How do we come in to assist such patients in the scenario you just created? Probably, like I have in our Hendo clinic, I have a case that was close to what you presented. So how do we assist such patients in this situation? Thank you.
Right. What I have seen happening, because I've got someone who is very close to me that's diabetes. So what I've seen happening in the Nigerian settings, because I mentioned, Dr. Bello will recollect this, that I mentioned that so many of these medications that I'm going to mention tonight might not be very relevant to Nigeria or may not be used in Nigeria. And I think it's coming to light now because you may not find some of this medication in Nigeria. But I'm just talking about current practice. This is what is obtainable this part of the world. Generally, what people tend to do in Nigeria is that what you will find out is that they are likely to go from, for instance, for this particular patient, although this patient is overweight, right? This patient has got an HB1AC that is about 8.2%. This patient is already on metformin, which generally helps with weight loss. So what people tend to do is that you'll see that when you look at some of the patients, they usually put them on insulin. Insulin, if you look at my presentation, I think I mentioned something about insulin somewhere.
Yes.
I think I mentioned something. I'll go back to the slide.
You did, yeah.
Now, this is what usually happens here. Where is the? I want to show you. I want to share this slide again. I'm sorry.
Yes, go ahead.
Sorry. Right. This is what usually happens here. Generally, this is what we do. We do it gradually. We don't usually like patient to be on, you don't want the patient to be on 3 medications or so, but sometimes you cannot avoid it. The patients keep deteriorating, their glycemic control keep deteriorating. So you have to add on another medication. This comes to what I mentioned earlier about cost as well. So if you are thinking of, oh, it's only cost that I'm going to consider, and the glycemic control, and you don't have optimum glycemic control, what's going to happen? You're going to have the more medication, right? So what tends to happen is that generally, I'm talking about this side of the world, this is what we tend to do. Sometimes you look at your patient, it depends on how the patient presents. A patient that acutely presents with very high, that comes with what we call HHS, right? And that is that's an diabetes emergency, basically. So a patient comes in with an HHS and you're trying to resuscitate the patient, you have to give them IV insulin and then you have to hydrate them. And then once you rehydrate them, you are likely to find out that sometimes some of these patients, if their blood glucose level is extremely very high, and you try to then put them on maybe they are already on maybe metformin on one of the or two of the medication, you tend to not think about any other thing because you want to give them something that will bring that blood glucose level down. And insulin is a very brilliant product. It's extremely very good. But we tend to delay the use of insulin. We tend to try, because most patients, when they hear insulin, they don't usually like it. Most patients don't usually like it because it means that they have to stick themselves every morning, about 3 times a day. So they have to stick themselves about 3 times a day. So most patients don't usually like doing this blood glucose monitoring all the time. But if they have something like tablet that they can take, they wouldn't mind. And that is why something like the GLP-1s that are used once weekly, this is where they come handy. But cost is a problem as well. So generally what I've seen is that in case of the patient that you've just mentioned, if you don't, I don't know the whole scenario about this patient, but if you have a patient who you are trying to control their blood glucose level and you have tried maybe 1 or 2 options and it's not working, the next line will be like probably insulin is available. And then generally we tend to use, on this part of the world, NICE said we should use Humulin high or the Insulatard. Those are basically intermediate acting insulins. That is what is recommended by NICE. Or if you have, or you can actually then use, or you can use the long acting insulin like the Lantus or the Levemir. So for some of our patients, we don't actually even give them any of these other 2, we don't actually go into maybe dual therapy or triple therapy, depending on the patient in front of you. We are clinical pharmacists, it needs to be individualized. Metformin, you can go on straight to add the insulin. And there are certain reasons. Sometimes you have a patient who is lean. Their BMI might be less than 22, or they present with an acute high hyperglycemia. So insulin is very good in bringing it down. Or you might be thinking of trying something like glycoside. It's also very good, but it's not going to bring it as quickly as insulin. I hope that answers your question.
Thank you, Pharmacist Ibrahim. Dr. Faith, can you ask a question if you're still online? Dr. Faith, can you go ahead and unmute yourself? Dr. Faith, if you are still online, can you go ahead and unmute yourself, please? Okay, there's a question here from Pharmacist Ali. Said, when a patient with type 2 diabetes, with diabetic foot, with uncontrolled sugar, what type of insulin should we use for this patient and the dose?
The question is the question is too it's extremely too broad. As clinical pharmacists, I think things needs to be individualized. In terms of, we need to actually know other things that's around this patient. I don't have access to the blood glucose level, right? So you have to look at the trend of the blood glucose level that tells you what type of insulin you need to prescribe for this patient. How high is the blood glucose level? And it doesn't necessarily mean that this patient will need insulin anyway. It doesn't necessarily mean that you have to put the patient on insulin straight away. It may be that this patient who has got this diabetic foot, you may be thinking of some other things. Possibly the SGLT, you can't use the SGLT2. So you might be thinking of the GLP-1s, but it's also expensive as well. So it depends on what is in front of you. If, for instance, let me just create a scenario out of this. I can create a scenario out of this. If I'm presented with a patient like this who has diabetic foot, and maybe the patient is acutely unwell, was admitted onto an acute medical ward, and I'm seeing the patient, and I found out that the patient blood glucose level, maybe, let's assume the blood glucose level is about, let me assume is about maybe 23 or 24. That's very high, right? Now, the diabetic foot, is it infected? Could it be as a result of the infection? So I will need to deal with that as well as dealing with the blood glucose level. Because one thing that drives blood glucose level up is infection. So if you don't control the infection, even if you give the patient 20 million doses of insulin and infection is not controlled, it will come down, but it will keep rising again. Right? So we need also to manage, that's why I was saying, you need to manage, we are not looking only at the blood glucose level when you are looking at your diabetes patient. You need to look at other things that I've mentioned earlier, those 9 processes that I've mentioned. You need to look at their lipid profile. If it's not well controlled, this patient will have heart attack. You need to look at their blood pressure. So it's not just one size fits all. It's everything. You have to look at the patient holistically. So if I want to narrow it down to say, okay, I'm looking at the blood glucose level. So I will look at, okay, what is the trend in blood glucose level? What time of the day is the blood glucose high? What time of the day is it low? Right? So, and then I will then look at those results and then be able to say, well, actually, if I give this, maybe it's only high for this number of hours. So if I give this type of insulin, maybe intermediate insulin will only work for about 12 hours. So if I give intermediate insulin, I know that the blood glucose level for this particular patient only rises for maybe about 8 hours. So an intermediate acting insulin might suffice for that particular patient. But if you have a patient whose blood glucose level maybe is high in the morning and then high at night, then you might be thinking, oh, maybe I'll give this patient the intermediate acting insulin twice a day. Or you might be thinking, oh, this patient is somebody, you also need to look at the patient. This patient is still young, or this patient is old, you don't want to give this patient twice a day dosing of insulin. So you might be thinking, oh, let me just give this patient a long-acting insulin. So there are so many things that you have to look at before you can arrive at your conclusion. Or is it that the blood glucose level is rising straight after food? So now you might be thinking about, oh, in that case, you might be thinking about using a mixed insulin, like your Humulin M3. So there are so many things, but it depends on the result of your blood glucose level that will make you decide on what you want to use, especially when it comes to insulin and so many other things as well.
Pharmacist Ibrahim. Now, to call on Dr. Williams, he has some clarification to make. Can you please submit yourself and make your clarification? Dr. Williams? Please.
Yes, the question I ask is with the understanding that as pharmacists, we treat patients as an entity, not a subsystem.
Yeah.
Everything about the patient should be considered. The patient clinical characteristics and our intended treatment outcome.
Yeah.
So the issue of cost must be carried along with other considerations that you have put in place. Now, in view of the weight gain effect, side effect of metformin, is there any other medication you would recommend vis-a-vis the cost of the one being recommended in our climb here? Because in Nigeria, the issue of national health insurance is another kettle of fish. That is in two. Not everybody is enlisted. Even those that are enlisted, you have to make part contribution.
Yeah, very right.
What's your take on that?
If it is this particular patient that we are looking at, when you look at this patient, I have looked at all the medications that this patient could use. And I started removing them one by one. Now, I don't know whether this one is available in Nigeria, the gliptins.
Yes,
I don't know whether it's available. It's available. Now, the only thing that I mentioned earlier about the gliptins is that we need to be very careful, especially in somebody who is alcoholic, who is drinking a lot of alcohol.
Yeah.
Now, so if this patient, you check this patient, you carry out a test, and this patient does not have any sort of pancreatitis.
Liver damage, yes.
Yeah, it's got a moderate liver impairment. It's got moderate liver impairment. But we need to look at whether it's got pancreatitis. If it doesn't have the pancreatitis, that might be an option to use. So the other option is the sulfonylureas that I've mentioned. This gliptins is weight neutral. It doesn't increase weight, it doesn't reduce weight. That's the good thing about it. But the sulfonylureas, obviously, patient will put on. This patient is already 32. he's over and above. So this is where it becomes a bit complicated. And I purposely choose this particular patient to make it complicated, for us to be able to see how complicated things are, and so that we can have this cross discussion. Cost is important. I've never neglected the fact that cost is important, especially in our side, in Nigerian side in our own side of the world. But at the same time, are we going to give something to a patient? Let's assume the patient has got pancreatitis. Are you going to give this patient gliptins? So it becomes a problem. Now, if you can't give, if the patient has got pancreatitis, are you going to give the patient a GLP-1 agonist? No. So that is even more expensive anyway. So I'm trying to remove drugs based on the problem that the patient has got. Pioglitazone would have been an option, but heart failure is contraindicated. It's very cheap. So what are we left with? The patient is already on metformin. The only other option for this patient is for this patient to have insulin, but we also know that insulin has some weight. So for some of our patients, I must tell us the truth, but for some of our patients, we do give them insulin, even if they are overweight. We do, because of the fact that we can see the fantastic work of insulin. If the patient agrees, it's all about the patient. And insulin is much cheaper than this other product that I've mentioned. It's much cheaper than this other product that I've mentioned. But it's all about discussing with the patient. Mr. AB, this is what is happening. This is the choice of medication you have. These are the side effects. You have these 3 left. Because of your condition, I could have given you this, but I can't give you this. It will complicate the problem. Now, this one, I can give you this, but you may put on more weight. And the problem with most type 2 diabetes patients is more weight. Except you are going to promise me that you are going to work on your lifestyle issues. But except maybe, especially in other part of most patients over there may not just give me something, let me take. And the other part of the problem is that are those patients actually coming back for reviews? That's the other part of the problem. That's part of the problem. Patients don't come back for reviews. But over here, patients, even over here, people run away from reviews. People are not sick. People run away. It's not that they run away, but they are busy. So, and then the problem becomes worse. And then you then have to find medication to give them. And then some of them are not complying. So it's the same problem all over. Because this is why I said the most important thing is to bring the patient onto your side. You have to find your own technique to convince the patient. In this patient, there is a trial that has been done that shows that if patient loses weight, if patient lose weight, they are likely to go into diabetes remission. Especially type 2, I'm talking about type 2 now. There's a trial called, what's the trial called now? Oh, I've forgotten the name of the trial now. Maybe when somebody's asking the question, I'll find out the name of the trial now. It's a remission trial. And that is why for people who fast, what you find out is that if somebody who fasts a lot, what you will find out, if you are not someone who then go back and eat all these sugary things and all of those things, but what you find out, especially for those, I have tried this before. I'm using myself as an example now. I've tried it before because there was a time I was calling back, because when you reach certain age over here, they start assessing your risk of having diabetes, especially when you come from, when you are a black background and then you are from Asian background. They will send, and when you reach certain age, they will send you letters to come in for a diabetes for a diabetes what they call diabetes risk assessment. Right. So when they send you, then all you just need to do is go and take the blood. You take the blood, and then this HB1AC. So when you take the blood, then your result will come, and then the doctor will call you in to tell you what your result is. So there was a time that my HB1AC was about was hovering around 4 close to 4 point something. So then he called me and said, my blah blah blah. I said I have to do something, and thank good enough, it was close to Ramadan, right? So it was around close to Ramadan. So Ramadan was about some few months later. So then I fasted. So after I fasted, right, lost a lot of weight. So what I realized that then I went for another checkup about 2 months or 3 months later after I fasted. What I realized was that the HB1AC just dropped down brown. So it shows that diet works, fasting works, losing weight works. And it has been shown scientifically that it does. So for so many of there are so many patients, even if you use YouTube, you will see examples of so many patients that have lost weight and have been able to control their diabetes. So many patients are only diet controlled. even if they are, the fact that they've been using tablets in the past or using medication in the past, they are no longer using medication because they have followed the lifestyle advice given to them by their clinicians. So I don't know whether I answered Dr. Williams' question.
Thank you, Pharmacist Ibrahim.
Thank you.
Time has gone, well, past spent anyway, so we want to round up. So at this point, I want to call on our chairman, Dr. Joseph Madu, to give the vote of thanks and the closing remark. I hope he's still online. Dr. Madu, if you are still online, please can you go ahead and give the closing remark and prayer? Dr. Madu, you are free to unmute yourself and go ahead.
Can I quickly say something, Dr. Bello? If you don't mind, it's just a quick one. There was somebody that asked questions about potential drug therapy problems of these drugs and cost of managing them and the cost effectiveness of the so-called expensive drugs compared with so-called affordable ones. We need to improve on our level. Right. The slide, you look, I'm going to send the slide to Dr. Bello. You look at the slide, that's what we call the ADA and ASD guideline. It's actually freely available on the internet. And you can look at it, you will see where, how they arrive at this guideline. It tells you everything about how they arrive at that guideline. So it's evidence-based practice, basically. So we can look at that. What was the other thing about it? Yeah, so and that's all I wanted to say.
Thank you, Pharmacist Ibrahim. With a very short notice, we thank you for this wonderful thing that you have just done today. So impactful and so educative. So let me call on our fellow pharmacist Lawal. Olashade, please can you kindly unmute yourself and help us give the closing prayer and remark, please? I know you are still online. Please, Madam, can you please go ahead, unmute yourself and give the closing package for our guest speaker, please?
Thank you for this privilege to do that. It's been a very interesting evening, and personally, I've learned a lot. Thank you, resource person. God bless you all. Let's pray. Father, we are grateful for and update ourselves again. Father, I pray that all that we have learned, we make good use of to know better and to do better for our clients and improve the welfare of the nation as a whole. Father, we thank you because we know you have heard us and you help us. In Jesus' name we pray. Amen.
Amen. Thank you, ma'am, for that wonderful one. And for our guest speaker, we thank you. We are so grateful for that. And for all our participants, we all appreciate your time well spent. Next month is going to be another one for CPAN special edition of clinical meetings. At this juncture, I want to say thank you and good night to everyone. Pharmacist Ibrahim,
Thank you very much.
Good night, everyone.
Good night, everyone.
Stay safe.
I'll send you the slides.
Have a pleasant weekend.
Thank you so much.
Thank you. Stay safe.
Thank you.